Welcome. In this session, we are going to start our discussion of the disorders of the efferent system, and we are going to begin with the disorders of the eye movement. First the infranuclear, then the supranuclear, and finally nystagmus. And then we have the disorders of the pupillary efferent system. Infranuclear disorders of eye movement arise from lesions damaging the nucleus of the ocular motor nerves or the nerve arising from the nuclei of the ocular motor nerves. And the pattern of presentation of a patient with infranuclear disorder of eye movement is usually one among the following three types. It can be an isolated mononeuropathy when only cranial nerve 3 or cranial nerve 4 or cranial nerve 6 is involved. The pattern can also be that of a multiple cranial nerve involvement in which more than one ocular motor nerves are involved. In addition, the adjacent cranial nerves, cranial nerve 5 and cranial nerve 7, may also become involved. And the third pattern is a cranial nerve involvement, either single or multiple cranial nerve involvement, but associated with additional neurologic signs and symptoms. And identification of any one of these patterns help us to narrow down our differential diagnosis with respect to the location and the etiology of the lesion. A lesion causing infranuclear disorder of eye movement can be located in the nucleus of an ocular motor nerve, can be within the intraxial or fascicular portion of the nerve which is located within the brainstem, can also be located in the extraaxial or peripheral portion of the nerve in the subarachnoid space, the cavernous sinus, or the orbit. Disorders of neuromuscular junction and disorders of muscles are also clubbed together with infranuclear disorders of ocular movement, but we will be discussing them in separate presentations. In this session, we are going to discuss the lesions located within the nucleus or the intraaxial portion of the nerve within the brainstem. The focus of this session will be discussing the associated neurological signs and symptoms which help us to locate the lesion. The patterns of strabismus with lesions in the individual ocular motor nerves will be discussed in the next session when we discuss the lesions in the extraaxial portion of these nerves. The symptom onset for an infranuclear disorder can be acute, insidious, or intermittent. Ischemic lesions, traumatic lesions, and inflammatory lesions of the ocular motor nerves have an acute symptomatic onset. However, even a mild trauma may precipitate an acute symptomatic onset of an infranuclear presentation if there is a pre-existent compressive lesion which was asymptomatic previously. Compressive lesions per se have an insidious onset, and myasthenia gravis usually has an waxing and waning intermittent course. The age-wise likely etiology of lesions causing infranuclear disorders can be congenital defects and birth trauma in infants, post-viral inflammation, trauma or posterior fossa tumor in children, trauma, demyelination, aneurysms, and arteriovenous malformation in young adults. And in older adults, the most common presentation is that of a microvasculopathic lesion of any of the ocular motor nerves whose risk factors include diabetes mellitus, hypertension, and hypercholesterolemia. Other likely etiologies in older adults include tumors and giant cell arteritis, which occurs in an even older age group. Workup of a patient with infranuclear disorder of eye movement is based on the likely etiology suggested by the clinical examination and may include imaging with magnetic resonance imaging, CT scan, magnetic resonance angiography, and computed tomographic angiography. An evaluation of blood glucose, blood pressure, and serum lipids is indicated if they are not previously known and we suspect ischemic microvasculopathic lesion of an ocular motor nerve. Evaluation of ESR, CRP, and platelet count is indicated if we suspect giant cell arteritis, and if a patient presents with multiple cranial nerve involvement, a nasopharyngeal examination is indicated because lesions at this site, such as mucoceles and malignancies, tend to have intracranial extension and involve multiple cranial nerves. A CSF analysis is indicated if we suspect an inflammatory, an infectious, or a neoplastic process. So how to approach a patient with diplopia? As a general dictum, lesions causing infranuclear disorders of eye movement affect the two eyes asymmetrically and usually unilaterally and result in diplopia. In contrast, Supranuclear disorders of eye movement, with certain exceptions, usually affect the two eyes symmetrically, and a patient with supranuclear disorder of eye movement generally does not complain of diplopia or double vision. On encountering a patient complaining of diplopia, we have to first characterize the diplopia. We should inquire whether the diplopia is monocular or binocular. In a monocular diplopia, the diplopia occurs in only one eye. That means the diplopia disappears when normal eye is covered. Whereas in a binocular diplopia, the diplopia occurs only when the two eyes are open, and diplopia disappears when any one of the two eyes is covered. We should inquire whether the patient experiences a horizontal, a vertical, or a torsional diplopia. In a horizontal diplopia, the two images of an object are separated horizontally. In a vertical diplopia, the two images of an object are separated vertically, whereas in torsional diplopia, the patient complains of this kind of an perception. We should also inquire about the variability of the diplopia in different positions of gaze, also known as incomitance. What that means is whether the separation of the two images of an object vary in different positions of gaze. We should inquire whether the diplopia is more when the patient is looking at a distant object or is more when he is focusing at a near object, and whether the diplopia is constant, intermittent, or fluctuating with a waxing and waning course, whether other orbital symptoms are present such as pain, numbness, and proptosis, and about history of associated diseases such as thyroid disorders, malignancy, generalized weakness, surgery, or trauma. We should also remember that a patient with a mild involvement may not report of a frank diplopia but may just complain of a blurring because of the minimal separation of the two images of an object, and patients with subnormal vision or language difficulties may not accurately describe the diplopia he or she perceives. Examination for diplopia starts with an external examination to detect a head tilt or a head turn. A patient assumes head tilt or a head turn so as to keep the eyes as straight ahead as possible. We should also evaluate the status of the lids, the orbits, and the pupils, because extraocular muscles and lids, orbits, and pupils are often involved together by a common lesion, and this is a very important principle which we must remember. We must assess the movement of the eyes, both individually for each eye, which we call duction testing, and also both eyes together, which we call version testing, in all diagnostic positions of gaze. And in mild cases, the ductions may appear to be normal. The next important test in a patient complaining of diplopia involves the use of a Maddox rod, and we can do a single Maddox rod test and a double Maddox rod test. In a single Maddox rod test, a red Maddox rod is placed in front of the right eye by convention, and the patient is asked to look at a white light source. So the patient sees the white light directly with the left eye and sees a red line oriented perpendicular to the Maddox rod with the right eye. If there is no diplopia, the white light source seen through the left eye and the red line seen through the right eye superimpose. And in a horizontal diplopia, there will be a horizontal separation between the white light source and the red line. And if the red line seen through the right eye is to the right of the white light source seen through the left eye, we have an uncrossed diplopia which occurs in esotropia, and if the red line seen through the right eye is to the left of the white light source seen through the left eye, we have a crossed diplopia which is seen in exotropia, and we can remember with a mnemonic X in exo and X in crossed. In a vertical diplopia, the red line and the white light source are separated vertically, and if the white light source is below the red line, then we have hyperdeviation of the left eye, and if the red line is below the white light source, we have hyperdeviation of the right eye. A double Maddox rod test can be very useful in a torsional diplopia because it not only detects a torsional diplopia but can also quantify a torsional diplopia. A Prismberg cover test, which can measure a horizontal or a vertical diplopia, cannot measure a torsional diplopia. A red Maddox rod is placed in front of the right eye, and a white Maddox rod is placed in front of the left eye in the same orientation. And then we ask the patient what he or she perceives. In a superior oblique palsy, which we often encounter in the clinic, the patient will describe that the image of the object seen with the eye with the palsied muscle will be oblique and below the image seen by the eye with the normal muscle. In prism burr cover test, we determine the extent of misalignment of the two eyes in all positions of gaze, and in acquired cranial neuropathies, the strabismus is concomitant. The extent of misalignment is maximum in the direction of action of the weak muscle. However, later on, the strabismus may appear to be comitant, with the extent of misalignment appearing to be similar in all positions of gaze. In addition to a double Maddox rod test, torsion of the eye can also be detected with the help of ophthalmoscopy. In superior oblique palsy, we will find extorsion of fundus in ophthalmoscopy, wherein fovea will be seen to be situated near the level of or below the inferior margin of the optic nerve head. Monocular diplopia is double vision occurring in one eye only, and it persists even when the other normal eye is closed, and it is usually associated with distortion of the image seen with that eye. In contrast, in binocular diplopia, there is no distortion of the two images of an object seen with either eye, but one of the images will appear fainter than the other. The causes of monocular diplopia include media aberrations due to abnormalities in the optical media, and the aberrations can be refractive or can be tear film, corneal and lenticular abnormalities. And monocular diplopia due to media aberrations usually disappear or subside with a pinhole. Maculopathy due to retinal fluid or an epiretinal membrane can also cause a monocular diplopia, and there is a rare entity called cerebral diplopia, which is also a monocular diplopia, and the diplopia occurs in either eye. That means when the right eye is closed, a diplopia will be perceived with the left eye, and when the left eye is closed, a diplopia will be perceived with the right eye. Differentiating a paretic muscle from a restricted muscle is important in strabismus, particularly when we are planning a surgical correction of the strabismus. And the most important test that is employed is forced duction testing. In forced duction testing, the examiner holds the limbal conjunctiva and attempts to passively move the eye in all the directions. In a paretic muscle, the examiner will feel no resistance when he is attempting to move the eye passively, but in a restrictive strabismus, a resistance is felt when the eye is moved in a direction opposite to the direction of action of the restricted muscle. Here in this diagram I show a right eye in which there is a long-standing lateral rectus palsy in which medial rectus restriction has also developed. So if the examiner holds the limbal conjunctiva in the nasal side and attempts to abduct the eye, the medial rectus will generate a resistance to this passive movement of the eye. With a paretic muscle, the saccadic velocity is reduced when the patient attempts to move the eye in the direction of action of the muscle, but with a restricted muscle, the saccadic velocity is not reduced when the patient attempts to move the eye in the direction of action of the muscle. Also, when the eye is moved in the direction opposite to the direction of action of the restricted muscle, the intraocular pressure may be found to be raised. As a general dictum, supranuclear lesions affect both eyes symmetrically, and the patient does not perceive diplopia or double vision. However, certain supranuclear lesions do cause diplopia, and these include convergence spasm or insufficiency, divergence insufficiency, ocular tilt reaction, skew deviation, and thalamic esotropia. And we will be discussing these entities in a little more detail when we discuss supranuclear disorders of eye movements. So starting with nuclear lesions. Nuclear lesions of the ocular motor nerves are relatively rare when compared to lesions in the extraaxial portion of the ocular motor nerves in the subarachnoid space. However, nuclear lesions are easily localizable because of the anatomic characteristics of the nuclei, and the close proximity of the nuclei of the oculomotor nerves to other neurologically important structures. So the lesion causing the infranuclear disorder can involve only one subnucleus of the cranial nerve 3, or it can involve surrounding structures with their own neurological manifestations. And it is important to recognize as the causes are prognostically important and occur within the brainstem, and the causes may be stroke, tumor or inflammation. Lesions in the nucleus of the third cranial nerve can equally involve or spare both upper eyelids. So either the two upper eyelids will be involved, which will indicate a nuclear lesion, or the two upper eyelids are spared, which also indicates a nuclear lesion. And this happens because the nucleus supplying the levator palpebrae superioris of either eye is an unpaired structure called the caudal subnucleus. A nuclear lesion of the third cranial nerve also involves the contralateral superior rectus, because fibers to the superior rectus decussate within the nuclear complex. However, both the superior rectus can be involved, as the fibers from one superior rectus lie close to the subnucleus for the other in the region of the decussation. The lesion causing dysfunction of the third cranial nerve can also affect adjacent vertical gaze centers in the midbrain, resulting in associated upgaze palsy. To judge whether a third cranial nerve palsy is due to a lesion in its nucleus or distally, we have the Darrow's rule, and which states that the conditions which exclusively indicate a lesion in the nucleus of the third cranial nerve is an unilateral cranial nerve 3 palsy involving the contralateral superior rectus, but may or may not involve the ipsilateral superior rectus with a bilateral levator palpebrae superioris involvement, or a bilateral CN3 palsy sparing LPS on both sides. There are conditions definitively ruling out a nuclear lesion. They include an unilateral ptosis, because the unpaired caudal subnucleus supplies levator palpebrae superioris in either side, a unilateral cranial nerve 3 palsy not involving the contralateral superior rectus, and an unilateral internal ophthalmoplegia affecting the pupil, because the Edinger-Westphal nucleus is supplied bilaterally by the afferent arm of the light reflex arc. So if we have any of these three conditions, then we can definitely rule out a nuclear lesion, and if we have any of these two conditions, we can definitively say that the lesion has occurred in the nucleus of the third cranial nerve. There are also other combinations of presentations in a third cranial nerve palsy, and they cannot either rule out or indicate a nuclear lesion of the third cranial nerve. A lesion in the nucleus of the fourth cranial nerve involves the contralesional superior oblique muscle, because the fibers originating from the nucleus decussate in the superior medullary velum. A lesion in the nucleus of the fourth cranial nerve can also be associated with other neurological features because of involvement of structures located close by. There can be dorsal midbrain syndrome, also known as Parinot syndrome, with a lesion near the aqueduct of Sylvius, and the features of Parinot syndrome involve impairment of upgaze, convergence retraction nystagmus, and light near dissociation. We can also have an ipsilateral Horner syndrome, because the first order sympathetic neurons descending from the hypothalamus pass close by the fourth cranial nerve. The lesion involving the fourth cranial nerve nucleus may also involve the brachium of the superior colliculus, which carry the afferent pupillary fibers from the contralateral hemifield, thus causing a mild contralateral arrhypedy. The lesion may also involve the medial longitudinal fasciculus, causing an ipsilateral INO, which we will be discussing shortly. And if the lesion involves the superior cerebellar peduncles, there will be ipsilateral dysmetria, that means an inaccuracy in reaching at an object, and there can be obstructive hydrocephalus from lesions obstructing the aqueduct of Sylvius, such as a pineal tumor. A lesion in the nucleus of the sixth cranial nerve causes ipsilateral gaze palsy, because the nucleus not only initiates abduction of the ipsilateral eye, it also initiates adduction of the contralateral eye through the medial longitudinal fasciculus. So the adduction of the contralateral eye is also limited in a nuclear cranial nerve 6 lesion, and a nuclear cranial nerve 6 lesion does not result in monocular ipsilateral abduction deficit and may not cause diplopia. This is in contrast to the cranial nerve 3 and cranial nerve 4, which supplies the respective muscles ipsilaterally only. Unlike supranuclear gaze palsy, a gaze palsy originating from a nuclear cranial nerve 6 lesion cannot be overcome with vestibular testing, which we'll come to in the presentation on supranuclear disorders of eye movement. Since the cranial nerve 6 nucleus is located close to the facial nucleus and the facial nerve, the lesion may involve these associated structures, and there may be an associated ipsilateral infranuclear facial nerve palsy involving both the upper and the lower face. It may also involve the ipsilateral MLF originating from the contralateral 6th nerve nucleus, causing a 1.5 syndrome. This we will be discussing in the next section. So coming to internuclear lesions. Internuclear lesions results in internuclear ophthalmoplegia, also called INO, from disruption of the medial longitudinal fasciculus called the MLF. So these are the two MLFs, the right MLF and the left MLF. The right MLF arises from the nucleus of the left cranial nerve 6, crosses over to the other side and then ascends to the medial rectus subnucleus of the third cranial nerve in the midbrain. So the right MLF causes adduction of the right eye when the left CN6 nucleus fires to abduct the left eye, and similarly the left MLF causes adduction of the left eye when the right CN6 nucleus fires to abduct the right eye. The most common causes of disruption of the MLF causing an INO are demyelination in young adults and stroke in older age. An INO can have several variants, as we will be discussing in the subsequent slides. Unilateral INO arises from a lesion in one medial longitudinal fasciculus, and the symptoms of unilateral INO include horizontal diplopia and difficulty in tracking fast-moving objects. The MLF, in addition to carrying connecting fibers from the 6th to the 3rd cranial nerve nucleus, also carries vestibular fibers controlling vertical movements. So a lesion in the medial longitudinal fasciculus can also cause vertical diplopia. The cardinal sign is slowed saccadic velocity of the adducting eye on attempted contralateral gaze, and the INO is named after the eye with slowed adduction. So if the lesion is in the right MLF, there will be slowed adduction of the right eye, and we call it a right internuclear ophthalmoplegia, and the range of adduction of this eye may be full or limited, and this is usually associated with abduction nystagmus in the contralateral eye, the left eye, when the lesion is in the right MLF, and this happens because of overfiring of the nucleus of the left 6th cranial nerve in an attempt to adduct the right eye. So in an INO, there is a slowed saccadic velocity of the adducting eye and a nystagmus of the abducting eye, but the cardinal sign is the slowed saccadic velocity of the adducting eye and not the nystagmus of the abducting eye. This is very important to remember. So this must happen, this may or may not happen. Convergence in INO is usually normal. In a bilateral INO, there is disruption of both the medial longitudinal fasciculi. So there is a slow adduction saccadic velocity of both the eyes and an abduction nystagmus of both the eyes. So when the patient attempts to look towards the right, there will be a slowed adduction saccadic velocity of the left eye and a abduction nystagmus of the right eye, and when the patient attempts to look towards the left side, there will be a slowed adduction saccadic velocity of the right eye and an abduction nystagmus of the left eye. A patient with a bilateral INO can also have vertical gaze evoked nystagmus, mainly in upgaze, because of lesion in both the MLFs due to interruption of the vertical vestibular pathways which ascend along the MLF. In the entity called wall-eyed bilateral INO or WEBINO, there is a lesion in the midbrain affecting both the cranial nerve 3 nuclei. As a result, the adduction of either eye is affected and there is exotropia in primary gaze. And when either nucleus of the sixth cranial nerve attempts to generate a gaze on the ipsilateral side, there will be an abduction nystagmus of the ipsilateral eye, but the contralateral eye will not move. In 1.5 syndrome, there is a lesion in the pons which involves three structures. It involves the ipsilesional nucleus of cranial nerve 6, it involves the contralesional MLF arising from the ipsilesional nucleus of CN6, and it also involves the ipsilesional MLF which arises from the contralesional nucleus of CN6, crosses over and passes through the lesion. As the ipsilesional CN6 is involved, ipsilesional gaze is not generated and there will be impaired abduction of the ipsilesional eye and impaired adduction of the contralesional eye. However, when the intact nucleus of the contralesional CN6 attempts to generate a contralesional gaze, there will be abduction nystagmus of the contralesional eye and impaired adduction of the ipsilesional eye. So the ipsilesional eye has an impaired abduction and an impaired adduction, and the contralesional eye has an impaired adduction, and the only remaining horizontal movement is the abduction of the contralesional eye. A pseudo-internuclear ophthalmoplegia can occur in myasthenia gravis when the same muscles are involved but at their neuromuscular junction, and pseudo-iono from myasthenia gravis does not have vertical nystagmus or vertical strabismus and improves with edrophonium. Pseudo-iono may also occur with paraneoplastic strabismus and long-standing exotropia. Lesions causing infranuclear disorders of eye movement can be ischemic microvasculopathy, giant cell arteritis, compressive lesion, infiltrative lesion, inflammatory lesion, or a trauma. Ischemic microvasculopathy occurs in older adults with diabetes, hypertension, and hypercholesterolemia. Characteristically, an ischemic microvasculopathy is almost always a mononeuropathy, that is, it involves a single ocular motor nerve. The onset is sudden and the deficit is usually maximal at onset, and only occasionally does the deficit further deteriorate, but the deficit never deteriorates beyond 7 to 10 days of onset. Typically, the patient does not complain of any pain, but occasionally pain is present, particularly in elderly individuals. So pain cannot be used to differentiate a compressive lesion from an ischemic lesion, and typically an ischemic microvasculopathy resolves within 6 months. So these three features are typical of an ischemic microvasculopathy and helps us to differentiate an ischemic microvasculopathy from other etiologies. Giant cell arteritis should always be suspected in new onset diplopia in an elderly individual with or without other symptoms of GCA such as scalp tenderness, jaw claudication, fever, myalgia, and others. So if an elderly individual complains of double vision, we must always screen for giant cell arteritis. In compressive and infiltrative lesions, the symptoms progress beyond 2 weeks and do not start to improve within 3 months of onset and may have multiple cranial nerve involvement. So these features are different from the typical features of an ischemic mononeuropathy and help us to differentiate between an ischemic and a compressive lesion. In patients with compressive or infiltrative lesion, there can be a previous history of malignancy. The other causes of infranuclear disorders of eye movement include inflammation such as demyelination, trauma, and a congenital lesion. A congenital lesion is usually associated with other brainstem anomalies. All the causes of infranuclear disorders of eye movement can occur with any of the ocular motor nerves. The last section we will be discussing in this session will be lesions of the intraxial portion of the ocular motor nerves, also called the fascicular portion of the nerves. The intraxial portion of the nerves are in the brainstem and thus the lesions occur within the brainstem. And like the nuclear lesions, these lesions may involve multiple closely located structures which helps with localization of the lesions. A lesion of the intraxial portion of cranial nerve 3 results in an ipsilateral ocular motor palsy in which the ipsilateral levator palpebris superioris and the ipsilateral superior rectus muscles are involved. in contrast to a nuclear lesion of cranial nerve 3. A lesion of the extraaxial portion of the cranial nerve 3 in the subarachnoid space may not involve the pupil if it is an ischemic microvasculopathic lesion, but does involve the pupil if it is a compressive lesion. In contrast, in an intraaxial CN3 lesion, pupils are involved to the same extent as the muscles and the lids. In plus-minus lid syndrome, there is ptosis in the ipsilateral eye and lid retraction in the contralateral eye. The ptosis in the ipsilateral eye results from lesion of the intraaxial portion of the cranial nerve 3, and the lid retraction in the contralateral side arises from the lesion also causing dorsal midbrain syndrome. A lesion involving the intraaxial portion of cranial nerve 3 may also involve the adjacent structures. If it involves the cerebral peduncle, there will be contralateral hemiplegia, and this is called Weber syndrome. If it involves the red nucleus and the substantia nigra, there will be contralateral intention tremor and ataxia called Benedict syndrome. If it involves the superior cerebellar peduncle in the dorsal midbrain, it will result in contralateral ataxia called Claude syndrome, and Knoth-Naegel syndrome is a constellation of contralateral ataxia with supranuclear ocular movement disorders and nuclear CN3 lesion. Since the intraaxial portion of the cranial nerve 4 is extremely short, it is difficult to differentiate a lesion involving the nucleus of cranial nerve 4 and the intraaxial portion of the cranial nerve 4, and so they are clubbed together and has been discussed in the nuclear lesion of cranial nerve 4. A lesion involving the intraaxial portion of cranial nerve 6 results in an ipsilateral lateral rectus palsy and not an ipsilateral gaze palsy, as happens with a lesion of the nucleus of the cranial nerve 6. The lesion involving the intraaxial portion of the 6th cranial nerve may also involve the surrounding structures. If the facial nucleus or the facial nerve is involved along with the intraaxial portion of the 6th cranial nerve, we will have an ipsilateral facial palsy along with an ipsilateral abduction deficit. If the corticospinal tract is involved along with the intraaxial portion of the 6th cranial nerve, we will have contralateral hemiplegia along with ipsilateral abduction deficit called Raymond syndrome. If the lesion involves the corticospinal tract as well as the facial nucleus and or the nerve along with the intraaxial portion of the 6th cranial nerve, there will be contralateral hemiplegia, ipsilateral facial weakness and ipsilateral abduction deficit, and this is called Millard-Gubler syndrome. And if the lesion involves the facial nerve, the nucleus of tractus solitarius of the facial nerve and the adjacent sensory nucleus of cranial nerve 5, we will have ipsilateral facial weakness, facial hypostasia and loss of taste sensation from the anterior 2/3 of the tongue, and this constellation of symptoms is called Foville syndrome. Thank you for listening.